Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And if you listen to PEM Rules and following PEM Rules, you probably noticed that today there wasn't supposed to be an episode. This is an off-schedule episode that I decided to do due to the increase in psychiatric presentation to the Pediatric Emergency Department. Something that I think all of us PEM clinicians and providers have experienced firsthand. Many children are coming to the Pediatric Emergency Department with suicidal ideation, suicidal thoughts, anxiety attacks, etc. So I figured it will be a great opportunity to bring to the show an experienced child psychiatrist who's been doing this for many years to get his advice about how do we better take care of these patients. Victor has been a child psychiatrist for over 25 years. He has trained many child psychiatrists and he's very experienced. So I figured it will be a great opportunity to learn from his expertise. So thank you, Victor, for coming on the show. I know how busy you are and I truly appreciate your time. Let me just introduce you to the PEM Rules listeners. Victor is originally from Long Island and New York City. He went to medical school at SUNY Downstate and did his general psychiatry residency at Hospital of the University of Pennsylvania, followed by child psychiatry fellowship at the Zucker Hillside Hospital in New York. Currently, Victor is the vice chair and director of the Division of Child and Adolescent Psychiatry at the Long Island Jewish Medical Center. He has been in that role since 2006. Victor, you have been with the Northwell Hospital System since 1982. Is that right?
Hard to believe, but correct.
That's incredible. Victor, you are currently the professor of psychiatry, child psychiatry, and pediatrics at the Zucker School of Medicine. You've been doing that for how many years now?
Since the medical school opened.
Right, and I know that's a fairly new medical school, is it not?
2009.
Right, that's what I thought. So thanks again, Victor, for coming on the show. How are you?
Good, thank you, and thank you for inviting me. It's good to see you.
You're very welcome. Good to see you as well. Victor and I met in 2000, like 13 or 14 years ago, when I was a fourth-year medical student doing my rotations at LIJ, and Victor was kind enough to drive me to and from the hospital every day because I was actually living in Boston and just staying in New York for a little bit. I still remember that time, Victor, and again, thank you very much for all the free rides. And the first question I have for you, Victor, it's a question I ask all my subspecialists on PEM Rules. What is your definition of a good pediatric emergency medicine provider? One who does what?
Well, it's a wonderful question, Yaron. And of course, let me begin by saying a good doctor in any specialty is a doctor who listens. So a good PEM doctor is one who recognizes what's urgent, listens carefully, knows what an emergency is and can distinguish what's critical, and listens to the story in order to understand the child and the family.
Very good. I could not agree more. You know, I often tell my residents and my medical students, now PEM fellows, to be a good PEM physician, you got to get a good story. Unfortunately, it's the reality of the situation that in pediatrics, the physical exam in children, especially in babies, only goes a long way or only goes so far. The baby often cries, you can't hear the lungs, you can't feel the abdomen. But when you sit with the parent and get a good story, I often find myself do what's right for the patient. So I appreciate you saying that. My next question to you, Victor, is one of the things that I see now more than before, and especially here in Las Vegas, where I moved 6 months ago, is children coming to the emergency department with acute psychiatric issues, whatever it would be. And oftentimes they're agitated. I'd love to hear from you, Victor, your advice about the approach to the agitated or severely agitated child in terms of drugs, behavior, what to do, what to say, what techniques can you give us PEM providers that we can use?
Well, certainly as we're entering a new phase of the COVID-19 pandemic, we certainly have seen a dramatic rise in acute psychiatric presentations to the emergency room for children and adolescents over the past 3 years. And specifically, the agitated child has always been one that deserves to be evaluated medically to rule out any organic cause. And a careful history from the parent or the guardian is really key because, as we've said earlier, you want to determine first any prior psychiatric history, any history of substance use, any ingestion that might have accounted for this. Try to understand whether the child might be on the autism spectrum, since we know that that's much more common than had previously been understood, as well as understanding the family in terms of any history of trauma, because unfortunately, trauma is so prevalent in our culture and in our society, and really is a thread throughout most people's lives. Some event or events that really marks their life before or after it occurs. So all of that, I think, is key when evaluating the agitated child.
Very good. I agree. So what I hear you saying, Victor, basically is psychiatric issues in the pediatric emergency departments are diagnosis of exclusion, correct?
Yes, you always have to rule things out to make sure there's no organic cause. And you want to understand any prior history, any trauma, and then listen carefully to the parent and the guardian to understand the context.
Great. So let's say, Victor, and unfortunately, I've been in that situation that, again, I want to sit with the child, get the story, sit with the parents, get a good HPI. But if the agitation, and that has been my experience sometimes, the agitation is just so severe and so significant. What approach do you recommend we take in terms of intervention, medication, so we can get a good story?
Well, look, obviously the best medicine is no medicine when possible. We try to avoid the use of psychopharmacology when we're taking care of children and adolescents. There are times when the agitation is so severe that we have to think about, is this something that would benefit from a benzodiazepine, such as a little Ativan, or are we concerned it might have a paradoxical effect, particularly if the child might have ADHD? And then we think more along the lines of something that could be helpful to calm the agitated child, at times even thinking a little bit of an atypical antipsychotic, something that might just acutely calm the child, but ideally try to do this without medication. And oftentimes I've been able to speak softly to agitated kids and say, is there anything you would enjoy to eat if I went to the cafeteria and brought you an ice cream? And sometimes they calm down and say, could I have two? And so I remember recently going to the ER and asking for 2 vanilla ice creams and brought it back. And the child looked at me very calmly and said, I think really what I needed was a good ice cream.
That's great. And I got to tell you, I have a lot of ice cream and a lot of popsicles in the pediatric emergency department. That's certainly something we can do. That's good to know. And I got to say, I love what you said. Let me make sure I heard you correctly. The best medication is no medication?
Correct. I think ideally, I try to talk very calmly, very softly. In fact, it can be disarming when we speak softly to an agitated child because in order for them to listen, they have to calm down and hear. That's true for people of all ages. It's true when the parent is screaming. It's true when the adult patient is screaming. And it's true when our colleagues are screaming. I speak softly and they kind of forces them to kind of calm down and try to listen attentively. So I think speaking calmly to an agitated child, offering them something to distract, something to eat. Can I get you a glass of milk? Would you like a soda? Can I get you some pretzels? And can be very helpful.
Very good. Great advice. The next question I have for you, Victor, is something that I'm sure you have seen, and we all know it, unfortunately. It's becoming more prevalent than it was several years ago. And again, especially here in Nevada, unfortunately, very, very often is the situation of the suicidal child. A teenager, or sometimes even younger now, who comes by EMS usually because he or she expressed some suicidal ideation, or even worse, had some kind of an attempt or some kind of an event that was interpreted as an intent. I'd love to hear from you, Victor. What is your approach to the suicidal child, and what can we do as providers to better mitigate the situation?
Well, once again, the last 10 years really has demonstrated a dramatic increase in the rise of suicidal ideation in youth. And, some people link this to the availability of the smartphone, which is really a small handheld computer in every one's hand with access to the internet and social media, both of which have potential benefits, but both also have potential dark sides. And that was preceding the pandemic, which exacerbated the already dramatic increase in suicidal ideation amongst youth. And the current figures suggest as many as 30% of adolescents have had suicidal thoughts in the previous 1 year. I mean, that's really profound. I can say that 40 years ago in our pediatric emergency room, we saw about 250 suicidal youth per year, about 20 a month. And in the past year, we saw about 6,000. And so it's been a dramatic increase in the presentation of suicidal youth. Now, we know that for the vast majority of the under 12 child who expresses suicidal ideation, they really are screaming for help and generally linking them to outpatient care urgently, not waiting, can avert an unnecessary hospitalization. Oftentimes, because of the lack of access to outpatient mental health care, even the under 12-year-old child may be hospitalized. Now, of course, there are some kids, even under 12, who have serious intent or have made a serious gesture or attempt, in which case they do require a hospitalization for medical stabilization and then for psychiatric safety. But the vast majority of the under 12-year-olds do not, but they do need mental health follow-up. And we've developed a rapid system of urgent care to hook them up the next day with outpatient treatment. So we've really been able to avoid the unnecessary hospitalization of the under 12-year-old child whenever possible. Now, the 13 to 17 age group is somewhat different. In that age group, we have children who have made serious suicide attempts. Many of them may end up in the intensive care unit until they're medically cleared. Unfortunately, we've also seen some who are successful in their attempt. And so we know that suicide in the adolescent population is a serious public health problem, currently the second leading cause of death in the adolescent population. And so suicide prevention is very much on everyone's radar and everyone's mind. So when we see the adolescent who's suicidal, if they've made a mild gesture or they've had mild ideation, the vast majority, once again, are not admitted. About 70% are not admitted, but we do see about 30% of the 13 to 17-year-old who have more serious suicidal ideation or attempts, in which case that group is admitted. And oftentimes the admission can be relatively brief, can be anywhere from several days to 10 days. The vast majority are in the hospital for under 2 weeks. An occasional child might be there longer, but the vast majority are treated and released and then return to their families and to outpatient treatment, oftentimes with a combination of antidepressant medicine, SSRIs, specific serotonin reuptake inhibitors, as well as cognitive behavioral therapy for their anxiety and depression. So we hospitalize about 30% of the 13 to 17-year-olds, but very small, 1% to 2% of the under 12-year-olds.
Very good. So those are very helpful numbers for us pediatric providers or PEM providers to know. And another thing that will be helpful for us to know, Victor, and let me explain. Over the years, as a PEM provider, I developed what I call the red flag theory. So as a PEM provider, I really approach things from an emergency standpoint and take you back for your medical school days. If I see a child with abdominal pain and the abdominal pain is on the right lower quadrant, that's a red flag. I need to worry about it. If the child is vomiting bile or vomiting blood, that's a red flag. I need to worry about it. So in my head, I have this list of red flags for every pediatric presentation that I see. And I'd love to know from you, Victor, what are the red flags for those kids who present with suicidal thoughts or suicidal ideations or behavior? What are the things that me or us as PEM providers should be aware of, ask about, etc.?
Multiple visits to the emergency room, previous hospitalizations, a history of depression even without a prior hospitalization, a family history of suicide that was completed, a family history of suicidal behavior, and oftentimes youth facing the consequences of some bad behavior, either facing suspension from school, perhaps expulsion from school, perhaps an adolescent on a PINS petition people in need of supervision, awaiting adjudication to determine whether they'll be transferred to either juvenile detention or perhaps a residential school. We know that those are critical periods because oftentimes youth, when they're facing the consequences of their behavior, may feel quite desperate and frightened. And so those are red flag periods. We also know in the immediate aftermath of a serious disaster where there's been trauma and loss, that youth can be at high risk. And I'm recalling an 8-year-old little girl who survived an accident where her mother and brother died. And she said, little girls shouldn't have to survive if their mother and brother dies. And so although she expressed suicidal ideation, it was really just the devastating reaction to the idea that she lost her mother and her brother. So I think there are many things to think about. Once again, all of them are part of the story. And, earlier you said EMS brings many of these kids, but actually many of these kids are actually brought by parents, guardians, and sometimes by school personnel, because it's most typical that these kids express something in school, either to a friend, and then the friend tells the teacher or the guidance counselor or the assistant principal, and then the family is notified and somebody from the school escorts the child to the emergency room. And so one of the things that we're really working actively nationally is trying to avoid unnecessary psychiatric hospitalizations for suicidal youth who have mild to moderate suicidal ideation, where oftentimes there's no access to alternative treatments in the community, and they're inappropriately hospitalized because there's no ready alternative. Now, the pandemic, once again, helped us with that because telehealth and telemental health became so readily available. And so in communities where there's no ready access to outpatient mental health services, now there's much ready access to outpatient telehealth services. So that really can be useful to avoid unnecessary hospitalizations because linkage can be made much more quickly, even if the therapist is at a distance.
So again, very important for us PEM providers to know. I'm going to ask you, I guess, so when you and I spoke a few weeks ago, trying to put together the topics for this conversation, you expressed interest, Victor, to talk about and discuss limiting access to social media and the dark side of the internet, with parents trying to delay access to both on smartphone until the age of 16. And you said that that's something that parents need to know about. And by all means, this is not a pediatric emergency medicine type of topic, but I'm more than happy to discuss that. As a parent, what do you want to tell us about that?
Well, first of all, although you may think it's not a PEM topic, I think it actually is, because many of the youth who may present to the emergency room have had some precipitating experience that may have come either through social media or through the internet on their phone. And so when we begin to take the intake histories, whether in the emergency room or in the outpatient clinic or even on the inpatient service, there's often something related to the social media experience, bullying, cyberbullying, information on the internet, which was teaching them something dark. And so I think asking youth what their experience is with social media and where they visited on the internet will often lead to part of the story that one might otherwise not think to ask. And the reason I support the idea of delaying access to the smartphone, which has both social media and the internet, is that it really is in keeping with the Surgeon General's current recommendation, that it does appear that we need more brain maturation and more psychological maturation in youth before they can really wisely and more safely manage accessing both the social media and information on the internet. And although 16 still remains a vulnerable age, it's certainly a more mature age than giving kids a smartphone at age 10, 11, or 12, which seems to be more and more common now, and parents feeling the peer pressure that the kids come home and say, everyone in my class has it. And of course, the telephone is important for communication, but right now, it's really not the telephone the kids are asking for, it's access to social media. And so many families are saying, let's band together. And I know of many communities where the PTA, the Parent Teacher Association meeting, will have speakers who come and talk about if the parents would form a coalition and say, let's give our kids flip phones so that they can text us or call us when they they arrive at where they're going or they're coming home and they want to notify us, but not access to a smartphone because the smartphone may be too difficult for them to really responsibly manage. And so I really think families should be talking with other parents in the community. I think that I've heard, fortunately, many parents now trying to delay this. Once you give a smartphone to a child or adolescent, it's almost impossible to take it away.
Yeah.
And so even though we say, listen, it's a privilege, you've earned it, if you break the rules, the consequences may losing smartphones, taking away a smartphone is like taking away oxygen. Kids become desperate. They're afraid of missing out because there was a middle of a conversation on social media. And if they don't participate, they're truly desperate. And we've seen, unfortunately, many very dark stories of kids where parents wanted to punish them and took the smartphone away after giving them a warning, and they become suicidal. In some cases, they attempt suicide. One child said, I didn't really want to die. I just wanted to punish my parents for taking away my smartphone. And so I think it becomes so gratifying. The dopamine rush that must occur with that smartphone is so addictive, and taking it away causes such distress that I think we really have to think carefully. And of course, here we are speaking, and we ourselves, and I can't speak for you, Yaron, but I know myself. How many times do I check my phone before I leave my house for the office? And how many times have I checked it today? And, we often will get a reading at the end of the day, at the end of the week about,
Yeah.
How much time we spent on our phone. And it's truly remarkable because if I think back to the pre-smartphone times, our daily functioning was quite different. And yet, I really like looking forward to the day without my smartphone. I intentionally leave it home sometimes when I'm not on call, and I'll go for a walk or a bicycle ride. And I intentionally don't take my phone with me because I don't want anyone to reach me. And I'll say, I'm going for a bike ride. I'll be home in an hour. I'm going for a walk. I'll be home in an hour. And there have been times where, my family members will yell at me when I get home and they go, I wanted to reach you. I said, I understand, but I didn't want to be reached. And I think that, we're living in a society where it's all instant. People used to leave a message or send us a fax or mail us a letter waiting for an answer. Now everything is instant. And of course, for the kids today, this is the generation that they've grown up in. They don't know anything else. And, when we say to them, can you imagine what the life was like before the internet? They look and say, what? How did you survive? And I say, well, I go to the library and look something up, and they look at me like, what a dinosaur. And of course, it was quite different. It was very nice, very different. Now, do I benefit and do I enjoy certain aspects of both social media and the internet? Yes, I certainly do. And do I try to limit my contact? I do. On the other hand, I think that I've seen too many stories and heard too many situations where it's really been toxic for many young people. And I think that PEM docs need to realize that they need to understand the implications of a younger person having a smartphone with the internet and social media, and even counsel parents in trying to delay access to that as long as possible.
Excellent. So my response to that would be, number one, I wish I had $1 for the patients that I've seen with psychiatric conditions in the ER that were instigated by my mom took my cell phone. So I can definitely attest to that. And I think it's a great advice, and I appreciate that. I'm sure some parents are listening right now. Delay, give the kid a stupid phone. That's what we're saying.
Many kids, and I'll give one example in particular,
Yeah.
find that the parents will feel like they're going to give their kid a special gift. And so I've seen kids at 12 or 13 where the parent says, I'm going to reward you for your good schoolwork or your good behavior, and give them a smartphone. And one 13-year-old boy recently, as soon as he got the smartphone, he visited some dark sites on the internet that 13-year-old boys might be interested in visiting. And before he knew it, every time the phone was closed, these pop-ups would appear on the screen, and he was mortified. So after a week, he brought the phone back to his parents and he says, I don't want it. Return it. I can't manage it. And the parents said, no, we'll teach you. He said, no, I don't want it. And I just think that if every kid would be as wise to realize that it's something that they couldn't comfortably self-regulate, because it can be so tempting to visit some of these dark sites.
Sure, absolutely. Victor, I so appreciate your time and coming on the show. Again, something psychiatric presentations to the ER, to the pediatric ER, is unfortunately something we're seeing, like you said, more and more of, and your advice were greatly appreciated to the PEM Rules listeners. I have a tradition in the podcast that I always try to play the outro of choice by the guest, and I guess you like Leonard Cohen and you wanted to hear the song Hallelujah.
I would love to hear it.
All right, so I'm going to do my very best. It's more of a piano type of song, and I can do piano, but we're going to come up with a special version, especially for you.
Great. Thank you so much.
Thank you, Victor, for coming on the show, and again, appreciate your wonderful advice.
Thank you.
And that is it for today, guys. Thank you very much for listening. I hope you learned something from Victor that will hopefully give you the tools to better deal with the psychiatric presentation to the Pediatric Emergency Department, something that we all have experienced increase of in the last few years. Special outro for today. Hopefully you recognize that song, and no, this is not a violin. This is the Picasso guitar bow, an incredible, very creative and super fun invention that I started using. Check it out on picassobow.com, and remember, if you purchase anything on the website, use the promo code PEM Rules to get a 10% discount. Alternatively, you can just click on the link at the show notes to get the same discount. Again, not violin. I have no idea how to play the violin. This is Hallelujah by Leonard Cohen with the acoustic guitar and the Picasso guitar bow. My apologies for the mediocre piano skills. I'm far from being a pianist. Hope you like it.